Okay, this is the Lipid Genetics Clinic brief video introduction to high triglycerides. So this first slide is meant to show you some of the physical manifestations of severe hypertriglyceridemia. So these are patients that actually have chylomicrons, so triglycerides typically in excess of 10 would result in these sorts of physical findings. So here in the central panel you can see the lipemic plasma. So compared to normal plasma that's been allowed to settle overnight, so here these are chylomicrons in the large triglyceride-rich lipoproteins, and so it's giving the plasma the consistency of a sort of a cream of tomato soup actually for the whole blood. So again, lipemic plasma in the presence of fasting is pathological and indicates a severe defect in lipolysis. The patient then would have lipemia retinalis, so on the fundoscopic exam. Other manifestations of severe high triglycerides, these lesions on the skin that look like acne almost, but they are in fact xanthomas. So these would be eruptive xanthomas on the skin, so occurring on the arms and legs and buttocks and trunk. Again, that would be severe hypertriglyceridemia. These are actually fairly reversible as the triglycerides are corrected. And then of course you can get these tubero-eruptive xanthomas which then persist. These are harder, not quite as reversible, and actually more related to smaller particles, remnant particles that one would see in dysbeta or type 3 hyperlipidemia. And here you might be able to see the palmar creases, a yellowish deposit. So normally in a say Caucasian person, these would be sort of pink or pinkish, but you can see that these are somebody with hypertriglyceridemia and type 3 in particular, type 3 hyperlipoproteinemia, these would be yellowish. So these are palmar xanthomas, and you may see these on the foot as well. There's xanthomas on the soles of the feet. So this slide is a busy slide, but just to remind you of the secondary causes of things that can raise triglycerides. So there's, in the category, these are lifestyle related, so things like obesity, metabolic syndrome, which has a definition of triglyceride levels above 1.7, where there's a positive energy intake and a high fat, high glycemic index diet, insufficient caloric expenditure, insufficient physical activity. Alcohol consumption is a big one. Alcohol will raise triglycerides in everybody. And diabetes, and particularly type 2, so high triglyceride, low HDL is the most common dyslipidemia in a type 2 in a diabetic. Renal disease, both uremia or nephrotic syndrome, will result in dyslipidemia, often high VLDL, high triglycerides. Hypothyroidism more typically is high LDL, but sometimes you can get high VLDL and hypertriglyceridemia. Pregnancy, triglycerides go up during pregnancy, and in fact in somebody predisposed, the triglycerides can go quite high during pregnancy. Physiologically they go up slightly. And there's some autoimmune disorders, so antibodies that are against the lipolytic enzymes, so paraproteinemia or lupus can rarely give it severe hypertriglyceridemia. And there's all of these medications, corticosteroids, estrogen, tamoxifen, non-cardioselective beta blockers, thyroid, thiazides, vitamin A analogs, bile acid sequestrants, which we use to treat LDL, which can cause the triglycerides to go quite high sometimes, cyclophosphamide, renal transplant patients, antiretroviral, especially the first generation drugs, and psychotropic medications often will, especially the atypical or the second generation antipsychotics. If your patient has high triglycerides, there are no targets for triglycerides, but we have general management paradigm. For triglycerides, if they're under 2, we just want to make sure that the LDL is at target. If the triglycerides are between 2 and 5, then it's really heavy on the lifestyle, so weight control, reducing dietary fat, simple sugars, reducing alcohol, increasing physical activity. Here we still try to get the LDL to target, manage the secondary factors, so particularly diabetes is often a common cause, reassess medications, consider lipid neutral alternatives, And then pharmacologic treatment, so often with statin therapy, with triglycerides in this range, you can intensify the statin therapy to improve the LDL, and that will help the triglycerides as well. Fish oil and sometimes niacin can help triglycerides. No evidence that niacin will reduce events when it's added on top of a statin. And higher triglycerides, say between 5 and 10, we intensify the previous steps. LDL cannot be estimated by the lab if the triglycerides are too high, and so therefore we can use the non-HDL or ApoB determination. Here you're into sort of fibrate territory, so bezafibrate, fenofibrate. Gemfibrozil combines poorly with statins. These other two fibrates combine well with statins, but certainly up in this range one would consider the added benefit of a fibrate. And then here above 10, we're trying to prophylax acute pancreatitis. So then there would be low-fat diet, complete cessation of alcohol, insulin for glycemic control, and then nothing by mouth. People are very tempted when the plasma looks lipemic to do plasma exchange, but really plasma exchange is just a sort of a Pyrrhic victory. It will clear the triglycerides temporarily, but if the primary source of the problem is not taken care of, there is no permanent solution by plasma exchange. And also, if you do these other measures, the triglycerides will correct just as rapidly as if you did plasma exchange. So we really don't think that plasma exchange is that helpful in this situation. It's almost an absolute indication for fibrates, and then for triglycerides above 10, you may want to consider specialist referral.